So welcome to everybody. It's absolutely brilliant to have you all here. I'm going to be handing over shortly to the Consultant Trainee Practitioners, to Consultant Practitioner Trainees to introduce and run this show. But first of all, I just wanted to say a few words. The first is just to say that today we're going to hear from people from a wide range of backgrounds. We're going to hear about their work during COVID. They also come from a wide range of settings, and they've been working with both old systems and new systems. And throughout this time, they've had to adapt and flex to all of the challenges that they've been presented with. So you'll hear some of that from them today. I'm Nikki Davey, and together with Abby Masterson, we deliver a quality improvement element to this programme and the leadership coaching as well. And we've been doing that for over 10 years now, although the programme's actually been running for longer. We usually deliver blended learning, so that's online learning with flipped classroom and also workshops face-to-face. But until today, we've been working virtually for the past 18 months, as our trainees have had to stop and start their programme, which again has been another challenge for them. I'm really delighted to welcome so many people online to join us and those in the room today. We've had absolutely unprecedented and unexpected interest from across the country, and I'm just going to name the places where we've had interest just to really show how much interest there is in these roles. So Cornwall, Essex, Surrey, Lancashire, London, Sussex, Bedfordshire, Northamptonshire, Yorkshire, Bristol, Oxfordshire and Ireland. People from all of those places have registered interest in this event. So I'm going to say a few thank yous in advance of handing over the reins, if you like, and I'm going to leave the trainees themselves to give the background to the programme. So my thank yous really are firstly to Fleur Kitzel. Fleur established this programme. She's sorry she can't be here with you all today, but she had the vision to bring this programme forward at a time when nobody else had really thought about that before. And so we've had several cohorts through on this fantastic piece to develop people and prepare them for that role of stepping up into consultant roles. So a big thank you to Fleur for that, and the commitment that she made to that, to launch it and to sustain it. And I know also the commitment she gave to supporting individuals through thick and thin to keep them on the programme and make it work for them. There's also some thank yous to the people who've mentored and provided support, which are the Pathway Leads. And we have some of you today in the room today and some of you online as well. Without the Pathway Leads, I think it would be fair to say that trainees would really have struggled to find the detail that they need for the support as they develop through each stage of their training. So that's been fantastic. I'd also like to recognise the people who are peers and the people who've gone before these trainees, some again who are here today, either virtually or in the room, the people who are already taking up consultant roles, who stepped up to that and are keeping the door open for people to come through behind them and, nurturing other people through the advanced practitioner roles, etc. And also, whilst COVID has been happening, I also just want to say a massive thank you to our current consultant cohort, because they have really stepped up to the mark. And what we have seen is the appreciation of the system as a whole in the responsibility that they have been able to take. And it's fair to say that many of them were asked to step up before they had anticipated doing so, and have done so and have learned so much through doing that. And I think that opportunity is something we really want to celebrate, and I hope really bodes well for the future for all of you. So we're going to hand over to them for them to share with you what quality improvement in particular and the leadership piece that they do in their program, has allowed them to do, and particularly in the last 18 months. So Anna, I'm going to ask you to hand over to you and take it forward. Is that all right? Here we are.
Hello everybody, my name's Anna Cheney, and for the purposes of this element of the presentation, I am a poor man's Shay Jackson. Shay is a now second year consultant practitioner on the physio and neuro and stroke pathway, who has unfortunately had to leave last minute because of child sickness. So she's a bit gutted that she can't join us, but I'll try and do her slides justice. So thank you ever so much for everybody for joining us. It's really great to know that this course and this programme is creating so much interest from everywhere. Today we'll be presenting some elements of the QI element of the programme and presenting some of the work that we've done. So I am a Consultant Practitioner Trainee. I'm a nurse on the Older People and Frailty pathway. And I'm in my 3rd year of the programme and hopefully due to finish in December. So this afternoon is a bit of a running order for you. It's a loose running order, but we'll be hearing about some of the QI work that myself and my colleagues have undertaken over the last 3 years. So some of it is during the time of COVID, some of it is before COVID, but it will give you a nice picture of what we get up to. We'll also be sharing some work for people in the room. There's some on the boards at the back, and we will be sharing it via the virtual space as well, so everybody can see the bits and pieces that we've got up to. We're going to invite questions at the end of all of the presentations. So we'll run the presentations and then we'll do a group panel where questions can be taken. We'll also have the online chat monitored so that questions from those joining us virtually can not be missed, hopefully. Everybody online, standard now, but if you can make sure that your cameras are on mute. Feel free to keep your cameras on if you'd like us to see your faces, but yes, muting your microphones would be fab, thank you. Okay, so the Consultant Practitioner Development Programme. So not everybody knows about it. I didn't know about it until I joined up, but it's a 3-year bespoke training programme funded by Health Education England South East. It supports trainees to develop across the 4 pillars of consultant practice. So clinical expertise, leadership, education, and research and innovation, all underpinned by consultancy. As trainees, we gained our places on the programme following a 2-part application process for each of the pathways you can see listed on this slide. So there are 4 pathways: frailty, mental health, midwifery, stroke and neurology. Today we're here to showcase our QI work and how it's complemented our development across the 4 pillars of consultant practice and lead us into a wide variety of roles within programme placements, secondments and substantive posts. Within the training programme, we have had access to training and coaching in QI methods provided by Nikki, Abby and her team at QIC Learn. I'm sure that most of us will agree that COVID has thrown some curveballs, to put it mildly, over the last 2 years, but it has also created an environment in which fast-paced innovation and change were absolutely necessary. And it was a challenge perfectly suited to QI methods. The QI methods and the QI practice that we're showcasing today span across all 4 areas of our clinical pillars. It's not unique to just one. So this is us. And we will, as we've said, we will introduce ourselves as we go. So, on to the presentations. We're going to roll through one person at a time, and it gives me great pleasure to welcome our first presenter, Tony King.
Well, I wasn't expecting that. Thank you. So thank you so much for coming into the room and virtually. My name is Tony King. I'm an occupational therapist in adult mental health, soon to be a consultant practitioner. And in my presentation, I'm going to talk you through my journey, which quite literally, don't tell everybody, but began 3 years ago in terms of quality improvement, because although at my interview, I said that I was doing great QI, I actually was on a completely different path and didn't know that there was this other place, this other pathway that we could be using. So I'll take you on a whistle-stop tour of those 3 years. So in the programme, we've been basing a lot of our work around the model for improvement. And I'm going to talk about a few of the placements that I've been on where I've used those QI methodologies and just try in my presentation to show you breadth in terms of place, in terms of people that you might work with or methods, and my colleagues will take us through depth in a moment. So we change placement every 6 months. And here, if we start with defining the aim, which is the first step of the model for improvement, this is an example. If you see the top corner, this is Health Education England, where Sarah, who you'll hear from in a moment, and myself were doing a project looking at allied health professionals in advanced practice. And our first step was really to collaborate to understand the problem. So we spoke to 36 AHP leads across the Southeast region. And really, we used the fishbone to try and identify some themes in terms of what the problem was. We used the Pareto to look at which are the most frequent problems. And then we used a driver diagram to try to really recognize the sphere of influence that we could have with only a short 6-month placement in a very complex system. So we found this approach really helpful in getting us down to a quite focused aim, which we felt we could influence and deliver, and we did. Ooh. That's not working. Okay, thank you. Second example, this is from a very early placement where I was on a ward with adults with dementia, and this is using a very simple formula. Staff gave me many examples of things that got in the way of them delivering good practice, and I used this formula to decide between 2 different problems. I learned with QIC Learn how to form a problem statement that had impact that would explain why we were going to look at a particular problem, and that it would be accessible to any audience, so not to people within the field, no abbreviations, no jargon. And from there to develop an aim, which for this one was to increase time spent doing enjoyable things alongside necessary things, which in a ward with adults with dementia, there's a lot of necessary things, but there wasn't enough enjoyment going on. I've pressed the wrong thing again. I've just done a little disaster. Now we're just going to get back on the, which I'm so sorry. Why does I'm only pressing the cursor. What am I meant to be?
We're back in the right place. I think we are.
Yeah.
Just click there.
Okay. Sorry. So second stage is thinking about measures. How will we know that a change is an improvement? So I used several different measures in this placement, which was the one with the adults with dementia, and they were not effective. So I ended up, I looked at mapping spaces, I looked at observation charts, and they were not reliable measures. So I had to review that with the staff. We thought about actually the aim changing to what is the value of these enjoyable things and measuring that. So then what happened in the end is we delivered groups that were for carers and for people that were living on the ward, and we involved the staff. We looked at impact, we looked at their feedback about how they enjoyed it, and we found that this was a much better measure, was to look at value. When I press that, it doesn't there. And I think the value speaks for itself. So images can be data. Second one about measures. This is quick and dirty during COVID, in a crisis team, super busy and needing staff's feedback live because we were working shifts, 24 hours, many changes and needing that information immediately. So the run charts, which many of you would be familiar with, became very important. And another example was with the Academic Health Science Network on the far side there, where we were implementing digital innovation across the region and wanting to simplify the process so that we could increase engagement. So using value stream mapping, we removed the red boxes, which are the no added benefit steps in the chain, and we were able to produce a much more simplified process, saving money, time, and increasing engagement. Let's see if the slide changes. Hey, I've got it. It's okay. So change ideas is the next step. Here's an example where I learned to check with clinicians. This was my first placement. CQC said that in this adult crisis team, the care plans were not written consistently. The manager advised that I look at how to increase written care planning within the electronic care record. And the staff told me that that would have absolutely no impact on the benefit to service users. So by checking with the staff, we were able to change the aim and make sure that we were actually delivering what we wanted. So we combined the two aims and had a multiple approach. So checking change ideas with people is really important. Here, change ideas with service users in a locked, secure unit. This was more of a challenge in terms of leadership, in terms of hearing what these women in the secure unit felt was getting in the way, and supporting leaders to hear that and to gather data to explore what was and what wasn't able to be changed. Ooh. Plan, Do, Study, Act, people will be more familiar with. This is that academic health science network that we talked about earlier on. For me, learning that the data analysis happens in the do bit was new, I didn't realise, and to map ideas separately. And then this, going back to that first example where we worked with Health Education England, this Plan, Do, Study, Act was in a large webinar asking the audience to carry out the activities and feedback to us in that stage. So this was really us trying to capture a much larger audience in that process. So these examples, I know it's a real whistle stop, but they are all captured in the slides within QIC and the link that we'll give you afterwards. But my key learning ideas that people share when they don't feel that they belong get lost, and ideas when they do belong as part of the solution get used. So that's my key learning. Thank you. I'll hand over to Becca. So you need to keep the cursor on that bit.
Thank you. That's good. Thank you very much. Lovely to meet you all. I'm Rebecca Savage. So I'm one of the trainee consultant practitioners in midwifery. Hopefully Tony's told me how to use the cursor now, so we'll be okay. So it's lovely to meet you all, both everyone who's online and in person here today. I'm just going to quickly take you through what it's been like, I suppose, to learn the QI myself and then to start moving towards supporting others in their own QI journeys. Give a bit of an example of that with QI coaching within the trust that I most recently worked in, and tell you a couple of other projects I've been involved in supporting, and then moving on to the importance of creating a learning culture across systems. So I'll do this briefly because I know Tony's just spoken about the journey as a whole. But I think really ultimately it's really important for me to acknowledge as well that I was a complete novice when I came to this programme 3 years ago in terms of QI. I'd come from a very clinical background, and although service improvement was within my awareness and maybe kind of wanting to make changes and seeing where there are opportunities to make changes, not really knowing how I could do that in an easy and put together format that I think really QI really does embody. So my first year I think was quite quick. If I was going to just sum it up, it was like a quick learning process, focusing on the small things. You know, picking the one small thing that you can have impact on, as Tony was saying there in some of our earlier attempts, and really importantly, failing fast and learning faster, I think was one of my key messages that I certainly took home from that. I think failure is one of those things that we struggle with within the NHS and as care providers, because ultimately to us failure means possibly harm. But you know, within a context of learning and shaping and safety, actually we need to be able to do that in a safe way and in an environment that helps us to learn and put things right quickly. So I would say I was probably a little over ambitious initially and went a bit big on some of my QI projects, but I soon learned that you had to really scale it back and pick something that you could impact. So some of the projects that I've been involved in supporting others, so moving through onto my third year now, the main one has been supporting the professional midwifery advocate within our trust to develop a learning process really for a midwife to take on a project of her own. I introduced QI and to the community midwifery teams within the COVID period, where obviously we've all experienced a great number of changes that had to happen quite fast. So it was introducing those tools that I could to support the community teams to make some changes that needed to occur. And then more recently, which I'll talk about a little bit later on, is working within the Academic Health Science Network and the Patient Safety Collaborative, which is what I now do. So now this hasn't come up, which is maybe I have to press something else. Hang on, because there's half of it there. There we go. I'm just going to click all these through. So the supporting learning with the PMA project, this is something that our PMA, which is a professional midwifery advocate, identified from her own practice with the birth afterthought. So this is not COVID related specifically, but something that happened within this last year. And I think is important to highlight from a service user perspective, has most definitely, COVID has most definitely impacted. We are seeing a lot more women, I imagine now, coming through birth afterthoughts, especially from COVID, with a degree of trauma that's going to be different from what they had before. So we were very keen to identify how maybe we could help improve the listening, specifically on the labour ward. And so a labour ward midwife came in to work with us. And to develop, really, the idea was to develop her own QI knowledge and experience. It could have been any project ultimately, but it was really lovely that it fitted with what she was doing. And she really took a lot away from that professionally as well. So I think we very quickly realised again that the project itself was really, really wide and very varied, and we could have gone down a number of different avenues, but it was really important to acknowledge where we could have impact and then to demonstrate the changes that we were making. It also became quite apparent, I think, in trying to support somebody else to learn something completely new, that although there was dedicated time there to do that learning, it was also difficult, I suppose, to do that without a framework. And so I very quickly pulled out all of my old QI things so that I could show and demonstrate how I had learned the process itself, and also how much I didn't understand when I first started, because it's not something I think that quickly goes into your brain. You have to keep practicing these QI tools and all the different parts of the methodology ultimately. And it certainly helped that we also got her a bit of access to our QIC Learn here with Nikki, which was fabulous because that consolidated everything that I had been trying to teach her on a one-on-one basis, and she got to kind of work through that in her own time. So that project didn't ever come to a conclusion within the time frame that she had to do that, within the days that she was given, but you'll see from the feedback here, I'll let you read that, that she really did gain a lot from it, having never really understood what QI was before, and how maybe that she could utilise it within her own clinical practice. She now is really coming, she's keen and she's really eager to take that forward. And I suppose it's a bit like me going through my second year and third year. Everywhere you go and everyone you talk to and everyone you work with, it suddenly all becomes, that's a QI project. You know, you're becoming one of those really annoying people that goes, that's QI, and trying to encourage them to do it when they're utterly not wanting to at this moment in time, which is really understandable. But I think that's important, again, just because it helps everybody to see the added value that one person can have, and the even greater value that more than one person can have when we start working together. So especially, again, I've learned the long and hard way that you really need a working party, you need a group of people. I'm a great ideas person, but actually I still need the team of people around me to help that come to fruition. It's not possible on your own. And I suppose that really leads me quite nicely onto that learning culture, and why that is so important within our safety culture. Risk is really, unfortunately, completely inherent in what we do in healthcare work, but I think it's important to recognise that safety ultimately is defined as the ability of individuals or organisations to deal with risks and hazards that avoid damage or losses, but still achieve their goals. So we're not trying to get rid of risk completely. It is always going to be inherent in what we do. We are people, and so are our service users. So the culture of an organisation, the culture of a profession is really important. And we talk a lot about safety culture, but I think the key here is that that learning culture is utterly underpinning all of it. So I now work, as I mentioned earlier, with the Patient Safety Collaborative. So I work with Wessex, PSC, and thankfully for me, I do that within the maternity and neonatal spheres, which is my knowledge base anyway, so that should be helpful. But for those of you who aren't familiar or don't link in specifically with an AHSN at the moment, they work across a number of programs. If you can see from the driver diagram here, a number of programs, 5 different programs. And like I said, mine is the MAP-NEO. So very specifically, we've got smoking and pregnancy, optimization and stabilization of the preterm infant, and managing deterioration. They each have different focuses within them as well. And I think the key thing to say about how I then go about, I suppose, supporting others in doing this work now is that it is all about communication and building relationships, which I think we all agree is essentially key to our role as consultant practitioners or any form of leader that we might go on to be within the NHS or another organisation. And I will leave it there and say thank you very much and hand you over to our next colleague.
Okay. Joys of technology. Hi everybody. So I'm Sarah Patterson and I am in my final year on the Consultant Practitioner Trainee programme on the stroke and neurology pathway. And I am going to tell you today just about a project I've been doing currently across the integrated care system in Dorset. With the population health management team. So it's a little bit about how I've brought QI methodology into another data management approach in bringing rehabilitation across the system. No, I'm going to have the same problem as Tony, sorry. Joyce. So a little bit of background to the project. Back in March time, while I was still working with Health Education England, was introduced to the integrated rehabilitation model. So this is a model that's been proposed by the Community Rehabilitation Alliance, and it's what particularly sang to me about it was it's very holistic, it's person-centered, and it's very much around the what matters to me approach. My clinical expertise, as I say, is as a physio in stroke and neurology, and my current research is around supporting people to be more physically active after stroke. So I've always had an interest in self-management and how we support people to return to activities that are meaningful to them. This was something really important to me, and we had the opportunity in Dorset to have a look at whether we might be able to pilot this model. Now, on initial conversations, we realised that actually we don't have a very good understanding of what rehabilitation need is in Dorset. So before we can start to pilot a model, how do we understand this better and know where we can look at implementing this model? We also need to know how we best meet rehabilitation need. How do we change that culture of thought about what can our service provide to this person to what does this person need? And so to start those conversations, not about what each individual clinician is able to provide, but what opportunities are out there across the system. So I started working within the population health management team hosted by Dorset CCG, and was using this approach of population health management. So it's data-driven planning to deliver more proactive care to support the needs of patients in Dorset. So the first thing that's been really important is really using data, as some of my colleagues have acknowledged, to tell the story. And one of the starting points was in talking to patients in the system. We understand, I think intuitively, my thought was that we understand how we deliver rehab further up the triangle. So you'll be able to see on that left-hand side, those kind of complex acute patients and patients with multiple long-term conditions with complex needs. I think we understand quite well, and we've got services to support them. But how do we provide a more proactive model to support people that are currently healthy or starting to live with increasing numbers of long-term conditions, to prevent them being that, needing that reactive service that we're currently providing? And speaking to patients who are currently waiting for rehab really helped us show that although they wait for a long time, when they do reach rehab services, it's not necessarily meeting their need. So this was Bob, who I spoke to as part of the project, and his expectations were really that he wanted some support with how to get back out and about. He talked about building himself a bubble, becoming self-isolated, and this is really what he wanted help with. And so there might have been many other services that might have been able to support his need, rather than waiting 14 weeks for a therapy appointment. But it was really important to understand this across the system, and as Tony said earlier, to be able to sense check whether this was kind of a true understanding. And so I did some work with the community rehabilitation teams, and again focusing on that bottom of the triangle. So I had about 30 conversations across the system, and within community rehab, most teams prioritise their populations according to kind of acuity and risk. And you'll see from that bottom part of the chart in the middle that it looked like there was potentially an unmet need, or a kind of different way of prioritising, that we weren't necessarily being able to provide that proactive rehabilitation to meet people's needs in the bottom of the triangle. Looking at process mapping, processes are really linear, pathways are linear, so often the wider offer services, so services to support patients to self-manage, weren't considered until the end of a rehabilitation intervention. And there was just then queries starting to come up as to whether we could look at a different order for that. And also being able to highlight again, to define what rehab need is in this population, highlighting that mobility and function were really key elements that people had needs around, and who was the best place and where was the best place to be able to support these needs. So just to, again, sense check, but on a wider aspect, I was using the same questions really about defining rehab needs, and starting to map some of the data that I was collecting across the system, but also across that triangle of need. So thinking about what the needs were for our complex and acute patient groups, but also what the needs were lower down the triangle to support people living with long-term conditions. And it was quite interesting gathering data from services such as Live Well Dorset, which are very much about supported self-management. Much of the need was again around physical activity, and this linked in with some of the lower prioritised patients within community services who had requirements around mobility. So again, it was just sense checking and using QI methodology to understand the characteristics across the system. And we were able then to start to get an idea, as you'll see on that right-hand chart, that if you look at the top of the triangle, so the light blue, people were very much talking about risk of deterioration, risk of admission, acuity and complexity. Whereas if you talked about people lower down the triangle, it was more conversations about managing multi-morbidity, helping people to understand their conditions and providing social support. So already we were starting to get some differences in the rehabilitation need of these population groups. And then just finally starting, I haven't finished the project yet, but this is kind of the steps I'm onto. So actually using driver diagrams almost towards the end of the project rather than the beginning, but to start to bring some change ideas for use across the system. So thinking at the 3 different levels, at a systems level, Dorset are really fortunate to have a very comprehensive dashboard of data, but starting to use some of the data that I've collected to identify markers so that we can think about what rehab need is to be able to proactively target those population groups. At a clinical pathway level, thinking about how we might be able to integrate pathways better so that we're not necessarily getting that linear referral to therapies and then thinking about supported self-management afterwards, but integrating pathways a little bit more effectively. And at the patient and clinician level, really a lot of work around that cultural thought about what matters to you through every kind of appointment, so that each time the clinician is working with a patient, one, thinking about what matters to them, but also about what else is available across the system that might be able to support this patient's needs. So just finally, how's this helped me moving forwards? Hasn't helped me to learn how to use technology, sorry. Really what this project has really shown me is how we can use data to tell a story. It's been helpful, as others have alluded to, using QI to bring structure to complex and big problems. So although we've got big data sets, it's enabled me to focus in on what the need and the problem really was. As I say, using data to tell a story to help explain change, one, reasons for doing things, and to help people really understand the current situation. So just kind of moving forward, I guess, into future roles, to be able to have that structure, that methodology behind me, to then be able to tell that story and bring people with you on a journey when you're trying to look at service change. Thank you very much.
Okay, so Sarah has gone very in depth with the data there, and I'm going to go very simple and back to the patient. So for me, I am COVID Services Manager for Dorset Healthcare. That's my day-to-day job. And when we were asked to rapidly step up a vaccination centre as part of the COVID-19 pandemic response, with my yoke as a nurse, on the Consultant Practitioner Programme, it was really essential to me that from that inception point, we provided a safe and effective, but also really positive experience for our patients that were coming through the doors, lots of whom hadn't been out for a year, into a very clinical environment, well, for a very clinical task, but not in a clinical environment. Most of the people that came to our vaccination centre in the BIC in Bournemouth knew it as either an ice skating rink or the place they'd been for a beer festival, depending on when they'd last been. So that was most paramount in my priorities when setting up my team and my service. So on January the 18th, we opened to the public, and this is Valentina. So Valentina was our first patient through the doors. She was very typical of the patients that we were getting through at that point. As I said, she hadn't been out of the home or out of her home for at least a year. In fact, Valentina didn't speak any English, and she was also in a wheelchair. So she was the perfect test patient for us to come through first, because she gave us some really amazing feedback and some quick fixes that we knew we had to make. So we used the input of the Dorset Healthcare QI and patient experience team to create a learning environment at the BIC vaccination centre. It was essential to me that they were part of the team from the beginning. We needed to create a learning culture. We used the basis of fix, improve and change as a really simple format for the staff that were working there and the volunteers and the security staff. Because they were all essential members of that feedback loop and that ability to fix things. We created formal and informal feedback routes from all of the staff, all of the volunteers and the public that were attending the centre. And one of the most successful elements that we implemented were whiteboards with keep, chuck, change and add on, which were in the staff areas and the volunteer areas, and anybody could write on them. So they were anonymous. As people walked past, if there was something they particularly liked or particularly disliked, they shoved it on the board. Didn't matter whether they were a volunteer coming for their first visit or the medical director coming to check we were doing things properly. Anybody was welcomed and encouraged to write on the boards. And we collected all of the notes off the board every day and discussed them as a team and talked about exactly what was within our power to change, what was necessary to change, and what wasn't necessary to change, but we should give some feedback to the staff about why that was. As a result of some of this anecdotal feedback that the volunteers were collecting from the patients as they were attending and they were chatting to them and sort of creating that slightly more comfortable environment, that more human environment for them, lots of people were suggesting that they were having difficulty getting from the car park up the hill to the entrance of the BIC. Originally, when it was set up, or when the mass vaccination centres were set up, they were not designed. NHS England hadn't imagined the older population coming to them. They thought they would all go to their GP surgeries. Actually, the older population just wanted to get vaccinated and they were happy to go wherever. So we needed to quickly put in a fix to help them get up the hill more easily. So we started looking for solutions as a team. So we discussed across our system with the CCG, we discussed with our volunteer organisations, local authorities, and it led to us being loaned 2 golf buggies, as you can see there, from the local golf course that was closed at the time because of the COVID restrictions that were in place. And the Vax Express was born. So evaluation, this is a short video which hopefully will work in a minute. It's very light-hearted and just shows the Vax Express in use. But we continuously evaluated, so every day we evaluated how well received the buggies were, how well they were being used, whether they were meeting the need of our population, whether they were still essential as our population changed as we went through the cohorts requiring vaccination. And this was done across teams, within teams, across systems, within systems. And virtual working was a massive barrier unblocker for us to allow us to have those conversations, but also for us to use a really simple but effective innovation to introduce people to QI, and that actually it's not a big scary thing. So we didn't use any, apart from the keep, change, chuck and add board, we didn't use any of the sort of traditional tools as far as they were concerned. In the background, obviously we were collating it all through the sort of data and bits and pieces, PDSAs that we would normally do. But for those that we were working with, it was just a way of structuring and framing those ideas. When the golf course reopened, they sadly wanted their buggies back. But one of the volunteers was so overwhelmed with what a difference they had made to the public coming through and how much joy they brought to people, that they actually donated £1,000 to the vaccination centre so that we could hire some and retain their availability. And we kept them up until July when we had to close for the cheerleaders. So hopefully this is going to work.
Click on the arrow on your screen, on the arrow on the side. There we are. It will come.
Bless them. They're very well liked. People still ask, people ask if we can have them back now. We really don't need them now. So this is my team, or a small part of my team. The vaccination team are a diverse group of individuals. We're from all professions, all walks of life, lots of retirees that have returned and we're now convincing to come back onto the register. And most of them had never heard or used QI before working with us. However, as I said, through the real life application and keeping it simple, we've been able to embed a culture of change and of learning within our whole team. And we hope that they'll continue to use the principles wherever else that they may go on to work. Thank you. When you click, yeah.
Hi everyone. Sorry, I'm a little bit behind schedule. I had an interview today for this current role as a substantive post. So anyway, I would like to introduce myself. My name is Emma Matthews, and I'm a Regional Community Development Lead, currently leading on NHS at Home at NHS England and Improvement. I'm also a Consultant Practitioner Trainee on my 3rd year here at the Older People and Frailty Pathway. And I'm also, in my spare time, an MPhil researcher for Bournemouth University. There, you have to keep doing it. Okay, so first of all, does anyone know about NHS at Home? Has anyone heard of it? Hands up. Cool, so that's a good thing, about half of you. So programmes in NHSEI are just that, so I'll tell you a little bit more about it. NHS at Home was born out of the pandemic, and it first started by request from Tim Strawn in the national team to consider how NHS at Home could be seen in people at home. So in wave 1, we saw people with COVID pitch up to ED far too late. They had silent hypoxia, their oxygen saturations were through their boots, and they died, unfortunately. And if they didn't, they ended up in ITU very, very sick. So this was an opportunity to really do things radically different and to pick up people with this bit of kit, although clearly it's not about the bit of kit, that could be picked up, monitor themselves, and sort of revolutionise how we manage people and look and monitor people at home. To date, over 10,000 people in the Southwest have been monitored via oximetry at home. And that's a huge underestimate because the data has had its challenges, hence why I'm talking about this now. So, I lead on the programme, but I could not have done it alone, and I have worked with this amazing set of people and all the AHSN really across the Southwest who supported the implementation of this and the implementation of oximetry at home across all of the Southwest systems. So there were gaps in the data, and we quickly realised within the second wave that we needed to support primary and community teams to better understand their data. And so the PCN lead within the Southwest region, Matthew Dolman, myself and the AHSNs enlisted the support of the Making Data Count team to take part in a 8-week QI data sprint. And the aim of the data sprint was for any PCN colleague to take part. There are 128 PCNs within the Southwest. They were all invited, anyone interested in data to come together. Okay, thank you. So Adam and Karen are from the National Making Data Count team. Now, usually you've probably heard of them in secondary care. It's actually very novel. They were the first time that those two individuals had come to work within primary care to look at SPC charts, statistical process control charts, and 60 colleagues within the 38 PCNs that took up the service took part. You'll be clear, I'm not showing any SPC charts here. That wasn't kind of the commission for the systems to do it, and they would share their data and learn in that space. So the systems collated the data, and this is some of the feedback that we had. So they were able to make some real-time decisions within their PCN. They developed some relationships, and we talk about the access to the data being really key. They had to access the data, work out Excel, even then to do their SPC charts. And that was a real challenge. And I think we need to be open and honest about that from the start. So it was a real learning curve for the Making Data Count team and us. And they felt better equipped. So this was the evaluation that the AHSNs did. Ooh. Okay, and then basically there was around, oh, this should have been, this isn't, sorry. So basically we built on those key relationships that were fostered during the pandemic. And I think it was really key to say that it was open and transparent. So a lot of the feedback was that, oh gosh, NHSEI, collaboration with AHSN, they're all different organisations, and how can we create that space that was open and learning? And I think this is one of the great things to come out of the pandemic, in this sense that this team could really collaborate and learn, and clinical leads who could actually openly share that they didn't know and they couldn't find the data, so we could connect them with people who could find data and really work at pace. And also, because it was 8 weeks, every week we learnt and they shared that data. I think, so what next and what could be done better? I think it was clear that some of the data was a real challenge, and we had 60 people come about in a sort of crisis situation. And I think it would be really great for them in the future to have a little bit more ability to use Excel and to buddy up with a colleague within another PCN, and perhaps for AHSNs in the future to be able to have drop-in clinics outside of this, so they could come. So you will see some resources there that are available. There's a Q Collaborative webinar which Natalie and Cheryl spoke at. There's a whole webinar series if you're interested in SPC charts, and there's a video just explaining of how to populate it via Excel. All of these we did along the way, and then if you want to know more about NHS at Home and the work we're doing, that's the space there. So yeah, any questions? Pardon?
We're doing group questions.
Oh, sorry.
That's all right.
There's a bit of a plug there if I had any more time, but we'll leave that. Ooh.
So thank you, everybody. That is the completion of our presentations, and we would now like to take any questions that you have. So if my colleagues would like to come and join me up at the front. Nikki, Abby, can you...
We'll pause the slide
yes,
so that they can see all.
Shall I stop share?
Yes, that'd be great, and then we'll pop it on just for the last bits.
Okay. Fabulous. Nikki, Abby, would you mind leading on any questions for us?
Sure.
Thank you.
Good. They're here. So there's a great question, which would be really good to hear each of your input into, which is, where are service users in this? Have you got any practical examples of where you use service users, and how generally might service users get involved? So I don't know, maybe in the order that you presented in.
Well, I did a very brief whistle-stop tour where I involved service users when I was doing a ward-based, well, both of the ward-based projects that I did, and carers particularly in the I just realised I'm not carers particularly in the ward-based QI that I did, and both times that sense making was particularly important and valuable, and sometimes you can be on the wrong path unless you're really checking it out with the people that are engaging with the service.
Great, thank you, Tony.
So I think, especially with the projects that we're doing at the moment, or sorry, the project that I spoke about, our data collection, it started from the service users, and the data collection that we did start to do was with the service users themselves, and that absolutely fed back into what then our change ideas were. And within the wider network, within the PCS that I'm working at the moment, co-production is really important to each of the programs that we run. And we at the moment utilise our MVPs, so our Maternity Voices partnership, and that's our main link way in from where we're standing as an AHSN. But obviously each of the trusts then utilise, they can use service user feedback in a more specific way, and they also have the MVPs as well to access. So there are kind of main ways that we would automatically gather data from the service users, and then obviously the clinicians that it's going to affect as well. So very much similar to what Tony was saying.
Thank you, Becca.
Sorry. Yeah, thank you. I think from the point of view of the project I've been doing, as I hope I demonstrated in my presentation, patient data and the service user has been really key and really central. I had Bob's story was really key, particularly in the workshops I ran to really help clinicians understand where we were coming from. And I also attended by an experts by experience group and got some input from them, and we had some really useful ideas and thoughts and examples of people in the community and how we can personalise care better. So I'd also just hope that with the change ideas going forward, that then also service users continue to be kind of involved in those discussions. So absolutely kind of at the centre of those projects. Thank you.
Thank you.
So in the vaccination service, we have tried to collect patient feedback from every patient that's come through the doors, as much as we're able to. But before we even opened the vaccination centre, we invited some patients with experience to come through and to tell us how they found the experience, essentially. So we invited a person living with blindness, a person living with hearing impairment, and a person living with Down syndrome to come through, and we got some really valuable feedback from them, but lots of anecdotal feedback received all the time.
Thank you, Anna. And last but not least, Anna.
Gosh, it's weird coming here. Oh, hi everyone. Sorry. For me, NHS at home is front and centre to people living at home. So the whole programme is actually now aligned to the Integrated Personalised Care team. And so when this work was first thought of, it was actually a pandemic and a bit of kit, and it's definitely not about that. So although there are some case studies on the NHS Futures website of a couple who the gentleman had COVID and his wife was supported by a GP. So it's 3 stories: his story, the wife's story as his main carer, and the GP. And I think it really shows how actually in the right place at the right time by the right person, those people can feel supported and enabled with digital technology as well. So I think that's key, but it's always about those people, not about the kit. And just to also add, I'm absolutely passionate about inequity, and some of why I did this work was really complex because of the different models that were happening out there when systems were upscaling this. So hence why primary and community care were really supported with their data. And also, it's really shone a light on some areas. For example, we know now that learning disabilities, people with learning disabilities are 5 times more likely to die of COVID. And so I'm working with the leads within NHSEI to see how we can support that inequity for winter, basically. And I'm also working with mental health for serious mental illness, which is clearly also another area that was missed or we could have done better in. So it's about constantly learning and constantly listening to how we can enable people to get access to services. It's a complex environment, but yeah.
Thank you very much. And we can continue the conversation in this room, but I think because we've got 38 people online, if I can just hand over to Nikki to briefly say thank you and to close the virtual part of this down.
Thank you. Sorry. The original screen. Oh, there we are. Hello. Okay, thank you. I was just going to we've got one more slide left. So I've got the same problem that other people have had and not being able to move it forward. Oh, there we are. Okay, so just really wanted to thank everybody for joining us. I'm really sorry that you weren't able to hear from Shay, because she does have some fantastic presentations and some wonderful stories to tell. We will be making those available. And so for everybody that's registered on this call today, it probably will take us a couple of weeks, but we plan to have both a recording of this session we've just had and also a space which you can go to, and you will find some of the resources and some of the wonderful examples that we've had today and heard about today. And you can look at them in more detail at your leisure and inquire directly to those consultant practitioners about their stories if you want to hear more. We're going to continue to carry on supporting them through the end of their projects. I'd like to thank you all, as I said, for joining us, and really 3 cheers to everyone for being brilliant and keeping going, and for everybody who's made it possible for this to happen today, because it has been a little challenging. And I'd like to thank Wessex, particularly Otterbourne, the staff at Otterbourne, and Jet and the people in catering, because they have made the impossible happen today. So thank you very much.